So last talk, consent issues and medical legal aspects. Again, I'm going to present the recommendations first for reasons that I explained. I think there are two important issues. We're going to follow with a discussion, and I'm going to raise more questions than I answer during the talks. But they're important areas, I think, as a result of the report, and important areas to discuss. The talk should have been given by David Bogart. Unfortunately, he's not able to be here, and therefore I'm his substitute. The key points in litigation: complaints about after awareness and about awareness are rare. Litigation is rarer. Deficient practice is not as rare. NAP5 provides a rationale and a defence against res ipsa loquitur, which we'll come back to. But I'm sure I don't need to. Our recommendations: there should be documentation that risks and benefits of an anaesthetic technique have been discussed. And amongst those, we include awareness. Preoperative written material may be an efficient way to discuss this, to achieve this. The anaesthetist who provided anaesthesia care at the time of report of awareness should respond promptly and sympathetically to the patient to mitigate adverse impacts. And that's part of the pathway that you've heard described earlier. Anaesthetists should keep clear, accurate anaesthetic records. There's nothing new in these recommendations, but I don't apologise for making them. And this is helpful in the defence of a claim. Equally, where a lapse has occurred, the accuracy of record keeping and documenting the lapse should mitigate against further outcomes for the anaesthetist, etc., etc. All reports of awareness should be carefully assessed, mapping details of the patient report against the conduct of anaesthesia care. And a model that could be used is the rigorous model that I think we've had in NAP5. So, litigation. We know a little bit about litigation due to inadequate anaesthesia. The NHSLA database is rather poor, but we looked at this a few years ago. So, focus on the fact we looked at 13 years' data in doing this. Inadequate anaesthesia ranks as number 3 in terms of the caseload of cases against anaesthetists. We are 2.5% of all hospital litigation. Our surgical and obstetric colleagues are around 80%. Not particularly costly, but it's a significant burden in terms of cases. In terms of what the litigation was, well, the pattern of those cases, the litigation is not very dissimilar to what we've heard about all day during today's presentations. They cost not inconsiderable amounts, £20,000 to £30,000 cost the NHS for each case, but there are only about 10 cases per year of awareness reported or that leads to litigation. Almost all of them lead to a payout. It's around 89% overall. In terms of the three groups, there's awareness, inadequate regional anaesthesia, which I'm not going to talk about, and drug errors. So there are 79 cases in those 13 years of litigation regarding awareness, not the majority, but an excess of which were obstetric. Remember, it's about 1% of general anaesthetics, and those are the issues. And awake paralysis, a smaller number. Put them both together, and you're just reaching 100. Still 8 cases per year. Similarities to what we've discussed. So, what did we find in NAP5? Well, in NAP5 itself, and we have to remember that when we got information from the local coordinator, it was often soon after the event. It could have been 62 years after the event, but it could have been the day after the event. So the number of cases of complaints and of litigation need to evolve. In the baseline, they all related to at least a year before, so it's likely that there was those had matured a little bit. So somewhere between less than 20% of the patients who have awareness are likely to complain, and around 5% are likely to litigate. And those numbers are not dissimilar in those cases which are clear operator error of drug errors. If someone wants to sue me, what do they need to show? They need to show I had a duty of care, which I'm anaesthetising them I have. They have to show that I've breached that duty of care in a negligent manner. They need to show that they have been harmed and that the harm has been due to a breach. Now, this raises the question about awareness cases, whether around the quality of care. We'll come to res ipsa loquitur in a minute. I've shown this before. The quality of care before awareness was not always brilliant, and the quality of care after awareness was much better, but there is still room for improvement. and we judge that a significant number of these cases, 73% of the certain and probables, 30% of the possibles where there's less clear data, and 100% of the awake paralysis were preventable by better care. So there's scope for patients to sue us, and I hope that that is not one of the outcomes of NAP5, but it's possible. A couple of vignettes where patient undergoing general surgery became aware in theatre, recalling specific aspects of conversation. The patient could not move, felt panicky, wanted to scream, they were distressed, felt violated, then lost consciousness. They informed recovery immediately on waking. The patient was greatly distressed, and after later psychological assessment, PTSD was confirmed. A clear, detailed record confirmed very low absent end tidal inspired volatile for around 15 minutes at the start of the surgery. This was a mind the gap case. The anaesthetist confirmed they forgot to turn things on. This may well have led to litigation, but it would have been settled very quickly because things were clearly documented. There was no attempt to hide anything or deny anything, and things were dealt with. Although the anaesthesia care was not great, it was dealt with in an appropriate manner, and things would have been sorted promptly should the patient have complained. Immediately on waking from a caesarean section, the patient recalled burning pain. This lasted for around 30 seconds. They then lost consciousness. They're seen by the same anaesthetist who the patient felt did not believe their account and said they were dreaming. They were very angry. The anaesthetic record indicated immediate initiation of volatile, but the machine log showed different, and the trust investigation concluded that the patient's statement was entirely believable. So there are two contrasting stories. Draw your own conclusions. The issue of res ipsa loquitur, which translates as the thing speaks for itself, is the rare circumstance, I'm told by David Bogod in courts, where it's considered that a case, rather than someone having to prove a case, that the case so much speaks for itself, it's bleeding obvious in another terminology, I suppose, that you don't need to prove it. And the question is whether this might be a mode of attack, as it were, or a mode considered in the litigation against anaesthetists for awareness. And I hope that as part of NAP5 we have shown some reasons why res ipsa loquitur should not be applied to awareness cases in anaesthesia. So not all reports of awareness had a general anaesthetic. Not far off a third hadn't. Not all reports of awareness were awareness. Not all cases of awareness led to harm. Some reports of awareness involved impeccable anaesthesia and no cause for awareness, so no breach of care, one could say. Others would have done the same. And of course we have no 100% reliable monitor to be discussed. So the NAP5 methodology, and lastly the NAP5 methodology could be used as a way of investigating these cases, but we think that it's not reasonable that everybody who whenever there's a case of awareness, that it should be automatically passed through to the courts as accepted. So the next area of contention and discussion is consent in the context of anaesthesia. You'll see this was a study that had a large number of authors and considerable discussion. So what do we tell patients? We're going to be moving on to the discussion in a few moments. When do we tell them and how do we tell them? And that's something for us as a profession to discuss. And I hope that the recommendations that we make in NAP5 will enable the profession to discuss that in more detail and come to a full decision. So we recommend that patients should be provided with information about the risks of anaesthesia, and this should include the risks of awareness, written if you wish. Patients should be informed of the possibility of brief experience of paralysis, especially where neuromuscular blockade is used. Although desirable to avoid these symptoms, a warning should prepare patients for the experience. We have to remember that it is the sensation of paralysis or inability to communicate which is most strongly associated with ongoing symptoms afterwards, with distress at the time and ongoing symptoms. Anaesthetists should ascertain the degree of information that the patients want and give it. Anaesthetists should form an opinion, a professional opinion, on the magnitude of risks to quote, based on the evidence available in the literature, making any estimate of magnitude quoted as obtained, how it was obtained. So we're not telling people what to say. You're all professionals, you need to decide what you're going to say. Anaesthetists should provide a clear indication that they've visited the patient and documented any discussions they've had. And particularly about sedation, sedationists should make particular efforts to ensure that the patients understand and that they've documented what level of sedation is being planned. Are we consenting for anaesthesia? There isn't any standard that says we have to have written consent for anaesthesia, but 44% of NAP reports included consent for anaesthesia. We don't know what the denominator is in those cases where there wasn't awareness. Only 2% of cases had documented a discussion of awareness before the awareness occurred. Communication involves, we believe, telling patients, discussing with patients in some form the risk of awareness, explaining, as we now know in great detail, what that experience might be, and also the issues around sedation. Illustrative picture. So what do we tell patients, and how do we tell them? I'm going to put my head on the block here. I am confident that the figure that we have of 1 in 19,000 patient reports after awareness, after anaesthesia of awareness, is robust of reports. And I'm also confident that when patients are enrolled in studies and consented for those studies, and then sometimes patients who are high risk for awareness and often paralysed, and then they are put through the thrice-Bryce questionnaire, you fairly confidently get an instance of 1 in 600. There's a gulf between those, and we need to try and work on how that is closed. But I don't think that anyone can be, I'm not comfortable with people being dogmatic and saying it is 1 in 600, it is 1 in 1900. People have to judge for themselves, not going to tell you what to say. There are specific circumstances where we know the risk is significantly higher, however you look at it, whichever papers you look at, however you consider NAP5. Obstetrics, the obese, predicted airways, and all those listed below. So perhaps those are patients where an individual discussion before anaesthesia should take place. And as JD has said, he's given you a whole load of instances with confidence intervals in the papers, should you wish to use them. Should you judge to use them? Paternalism versus information. Should we tell everybody with a neuromuscular block, or everybody who's having a neuromuscular block in obstetrics, or everybody who's obese having a neuromuscular block, about the risk of awareness and the risk of a sensation of paralysis? But what I think we can be confident about, irrespective of those discussions, is what we can tell patients about what awareness might feel like if they do have it. And I think this can be informed by NAP5 and can be reassuring. And we can encourage patients to tell us about their episodes of awareness if on the infrequent occasions that they have them. Consent and sedation. 20% of NAP5 awareness cases were after sedation. We judged 80% of these to be preventable with better information. Do we care? They had sedation, they complained about awareness after general anaesthesia. They were wrong, they didn't have it. Well, we should care. This is a patient who had a knee replacement. They had a spinal and femoral nerve block and sedation with midazolam, and then 9 months later they reported having been awake, caused fright, lasted for quite a long period of time, and they had distress afterwards. There was no documentation of written consent for sedation. I've changed my practice since starting NAP5. What does the literature tell us? Well, this was a nice little study where they went through the notes of about 110,000 patients, some of whom had had a general anaesthetic and some of whom hadn't. And they asked them if they had experienced any problems related to anaesthesia. And the same number of patients reported awareness after general anaesthesia who had a general anaesthetic who didn't. It's absolutely identical. And another nice paper in anaesthesia where patients, this was 117 patients who'd had regional anaesthesia or managed anaesthesia care, and they asked them about how they'd been told about what they would experience. Most of them experienced complete unconsciousness in spite of the intention being sedation. Most of them expected unconsciousness, and only a minority, not a minority, only 60% had those expectations set by the anaesthesia provider. What would it be in the UK? In the ASA awareness database, a third of the patients who have signed up self-reporting to the awareness after general anaesthesia database in the States didn't have a general anaesthetic. So when they've pulled the notes of about 90 patients, they found that a third of them didn't have a general anaesthetic, they had sedation. But if you then look at the experiences they had during their episode and the psychological sequelae afterwards, they're almost indistinguishable from anaesthesia. And as you've heard, that's almost the same as what we found in anaesthesia. So I think it is worth emphasising, in spite of this being a study of general anaesthesia, that when we're going to sedate patients, and we hope not just anaesthetists, that they should have an explanation of the altered level of consciousness, that it's a change in perception mainly, that it's not general anaesthesia, and amnesia may be variable. And that is now my practice. And I think that's Mike's table, which I hope will be increasingly used. I think it's very valuable. I think that's the end. Thank you very much.